everybody. Thanks very much for inviting me. So before I give my disclosures, I'll play a little video from our friends at Google. Many of you would have played Atari Breakout. This is them teaching a machine to play the game. What's important to know is they didn't give it any rules. They just said, here's how you move the bucket, and this is how you maximize the score. And you can see at the beginning, it's really not doing very well. It's not scoring many points at all. After 120 minutes of training, it starts to play like an expert. And it's racking up points very, very quickly. With even more training, it gets really interesting. It's where the magic happens. It realizes that by digging a tunnel through one side of the screen, it can actually get a score which outperformed humans. So is it really the rise of the machines? We'll discuss that. So my name is Chris Mancy. I'm the co-founder and CEO of Viz AI. What is artificial intelligence? Well, AI's been around for about 60 years, but until recently, it really hasn't delivered anything of particular value to the field of medicine. But things are starting to change. And it's starting to change because we can now combine significant compute power with labeled data and deep learning. And deep learning I'm going to go into, but it's essentially a technology that learns with each and every example and gets better the more labeled data that you put into it. It came into the forefront in 2012 during the ImageNet challenge, which is like the Olympics of computer vision. And a network called the AlexNet was entered by an academic group out of Canada and completely crushed the competition, which included Microsoft, Google. It's based on the structure of the brain. You take a neuron-like node, you take inputs going into something similar to a synapse, which is essentially a statistical model, and then it gives an output. And you layer these nodes into layers and combine millions of layers in order to learn. And each and every time you put a piece of data through the system when you're training it, those weights, that statistical model, either gets stronger or weaker until it can take an image like this and output, yes, that it thinks that's an ICH. How do you train it? Well, you first of all need to tell the algorithm what it is. So here a neuroradiologist has just categorized this image as an ICH and is going to segment the vessel by drawing around it. You take those annotations and you're training, you're saying, here's the answer. And it's starting to learn it. And initially, as it starts to learn, it makes lots and lots of mistakes. But over time, you start to see an exponential learning curve as it learns from every example. What we're trying to do here initially is enable computers to see. And here we've enabled it to see an intracerebral hematoma. And also because you know exactly what each voxel shows, the volume can come out of it for a simple calculation. Can also tell the difference between interparenchymal hemorrhage and intraventricular hemorrhage, between a subarachnoid hemorrhage and intracerebral hematoma. It can segment a vessel and look for large vessel occlusions. It can pick out things like the hyperdense vessel sign. It can detect things like aneurysms. And here's a video of it detecting both a basilar and an MCA aneurysm. Here it's looking at for core infarcts. The middle is the annotator's ground truth, and you can see actually the algorithm did even better than the annotator as it was able to pick out the hyperdensity in the insula. You can also recognize faces, and that becomes relevant, as we've seen in some other talks, with detecting things like gaze deviation and facial droop. And as David, the CTO of the company, stimulates facial droop, it's able to pick it out. So, with enough data, expert-level results become possible. And we've seen this in ICH with a 0.985 correlation between volume estimates of a neuroradiology group and the algorithm. Sensitivity and specificity around 90% for large vessel occlusion. But all of that, does it really matter? Is it clinically relevant? So in stroke, as we all know, time is brain and workflow is complex. We know that today it goes in series. But what if, instead of that, you could have an algorithm that read every scan, and if there was a positive finding of some sort, it could alert the whole team at once and allow them to communicate with each other and move that patient from spoke to hub faster, from the ER to the angio suite faster, reducing door to groin and door in, door out times. So with our commercial platform Viz, we do that. We alert within a network on suspected large vessel occlusions. In this case was a 69-year-old female whose last known well was 2 p.m., came in at 6:02 p.m. with a suspected stroke and had a non-contrast CT, a CTA, and a CT perfusion. The timing is very interesting because this shows how AI on its own is actually not particularly useful. You have to put it within a system that actually is usable by the clinicians. And by that, I don't just mean the neurointerventionist, the neurologist, but also the ER physicians and nurses. Here we can see that the CT angiogram was completed at 6:26. Then, if you can read, it says at 6:30 an alert went off, and a little small, but at 6:30 the LVO alert was sent. At 6:31, 1 minute later, the stroke nurse, the interventionalist, and the neurologist, all in different parts of the hospital, all look at the scan. 1 minute later, at 6:32, the neurologist writes, TPA given, we'll discuss left M1 occlusion with Harris. The perfusion scan comes through. We know this patient's still in the scanner at this point in time. And then a few minutes later, at 6:41, the interventionalist says, tech and nurse there for other case, collaterals look great, plan for intervention. So you can see how by alerting the right people at the right time, you're able to synchronize care and move these patients around much faster. And we were seeing significant time savings that have been presented independently from me during this conference, and we're studying this at the moment. We think the biggest effect is going to be on door in, door out time, where you don't have the optimized comprehensive stroke team in the hospital with the patient. So actually, we can skip over some other diseases. We're working on a bunch of different things. One thing that's, I think, very interesting to this group is how it might be used outside of clinical care. This is an example from the ENRICH trial where Viz was able to detect a potential enriched patient. So it identified that there was a patient with an interparenchymal hemorrhage. It identified the location and the volume. The surgeon was able to go into the case, look at the images, and then run through the pre-randomized screening criteria, the inclusion-exclusion criteria, and then perform an e-consent on this patient. The hope is now that we can include more patients in our trials and get to answers about whether treatments are effective or not much faster. Controversies. So for those of you who weren't around yesterday for the conversation and controversies debate, I wanted to show you a clip from the debate yesterday because AI isn't necessarily all good. What do you get if you combine Dr. Raul Nogueira with Sylvester Stallone? You get this.
You gotta be willing to take the hits and not pointing fingers saying you ain't where you want to be because of him or her or anybody. Cowards do that, and that ain't you. You're better than that.
This was him talking.
You talking to me? You talking to me? You talking to me?
Thank you.